Dr. Aparna. I think that was a very generous welcome for a lot of people who know me because my father works here in not in. Hello. So. Yes, ma'am. So my father is a general practitioner and works in Malvani, and I think Badwe sir and a lot of people know him very well. And that is how I get my identity. And I'm very proud to be identified from my father rather than me being identified as myself. To give you a brief of what I do, I mean, she's pretty much given everything. Dr. Aparna has told where I studied, what I did. However, I've had a significant amount of experience in the UK. I've spent about 15 years there. And I came back in 2018 to start my practice here. So what is the scope of my practice? So my practice principally is as a sports surgeon. And I do all kinds of sports injuries. I do arthroscopies, which is the flavor of this decade, I would think. And what is arthroscopy? Arthroscopy is nothing but camera-related surgeries. So we put a camera and we do everything that we used to do open, now with a camera. Often known by the patients as laser surgery. However, there's no laser involved, but it is a means of them to understand. I do a lot of joint preservation surgeries, which essentially means that the joint that is naturally given to us by God, we try and protect as much as we can. Obviously, there are certain parts that we cannot. And when we can't, we can't. But we try our level best to preserve what we have. And then I do replacement surgeries, but I limit my replacement surgeries to the upper limb, which means I do shoulder, I do elbow, I do wrist, and I do finger. So there are replacements, it's just that it takes a little while to get them in the country. We have currently got shoulder and elbow in the country. Wrist and fingers are in the process, and we should have them in the next couple of years as well. And I do all kinds of complex work. So things that don't get solved, I solve them. So to come to the theme, which was sports injuries, I'll probably think about 70% of the sports injuries are minor sports injuries. Fortunately, we've got Goregaon Sports Complex, which is just next door, and this belt of western suburb now sees a reasonable amount of sports injuries. Previously, sports injuries were fairly limited across to the Villeparle section and Bandra section because we used to get a lot of sports club working really hard there. And the next section was across the town. So now we get a lot because of the Goregaon Sports Complex, and it's a very flourishing and a well-known complex across the western suburb for all sorts of sporting activities. Hence, we get injuries. So for minor sports injuries, it often comes to the general practitioner as the first point of contact. Because parents don't think it is significant, athletes don't think it is significant, and they come to you. So how do we treat them? The treatment is very simple. Treatment is rest, followed by icing, followed by compression of the part, elevation to reduce the swelling, some kind of support that could be used as a splint or a plaster if you are able to do that, and non-steroidals. You do this much and you have treated 70%. The things that don't get treated are probably not going to get treated by you anyways, and the patient often comes to us either in an ambulance or on a stretcher. And they were always going to come to a hospital for it. And those are major injuries. Now, they can be classified based on the joints that get injured. The most common two joints that get injured in a major injury is a knee and a shoulder. So a knee and a shoulder is the most commonest joint that gets injured in sports. So that is a knee sports injury. Now that is going out of the field on a stretcher. It's not going any other way out. We get that in cricket, often or football. Now, football is picking up as well. Behind Ozone is where my son comes to play football because there's a Barca training club here. So football is picking up like hotcake in the younger generation. So what do we get? In the knee, the commonest thing that happens is a ligament. The commonest ligament that you hear is an ACL. So ACL is nothing but the central ligament of the knee that holds the knee together. When it gets injured, you get what you call as a tear. And that is what it looks when we put a camera inside. So it looks completely shredded. And you can see it's completely shredded. So that's an ACL tear. So how do we deal with it? Now, people who play often require reconstruction of this because without ACL, they'll not be able to cut through. So any change in direction will cause buckling. So that is what a normal ACL looks like. I have an idea. It's a nice shiny structure in the center of the knee. And that is what we do with it. So we take a graft, which is either a hamstring graft or any other tendon that is available in the same leg. We make a cord out of it, which looks like an ACL. And we put it inside the knee. We attach one side in the femur and attach the other side in the tibia. And then it should work. Or it should be like an ACL. The next biggest is rehab. It is often discounted. It's often that ACL ho gaya to ho gaya. It doesn't work like that. I am just giving a cord, which before the cord was an ACL. So that cord has to be trained to become an ACL. And that training is what physio does for us. Now, the current और the age-old myth is ACL हुआ है 9 महीना साल भर कुछ नहीं कर पाओगे. That is what people would say. That is no longer the case. In the current genre era of sports medicine, we are doing everything fast. So this is a little video of one of my patients where I'm not sure if you can hear it. But he is talking about not to be scared of ACL injuries. And he's talking about how he is currently about 42 days from the surgery. Okay, and he'll show you in a minute how much he moves in 42 days. When I say 42 days, that is a month and about 15 days, right? That is like a 1.5 month. So this is a 1.5 month recovery of somebody who's had an ACL reconstruction with a standard technique. There is no rocket science to this. And he'll show in a minute how much he moves. So he tells you that he's able to walk stairs, he can go down the stairs, he can go up the stairs, and this is how much knee bend he gets. And this is how much knee straightening he gets. His life is back to normal, he's back to work, he works in a lab where he has to climb stairs up and down, and he does everything. So there's no restriction per se. However, that does not mean this is the end of his road. He still has to continue doing physiotherapy because the knee keeps getting stronger and stronger and stronger as time goes on. So that kind of is a nutshell what an ACL is all about. So which brings us to the next structure in the knee, which is the meniscus. So meniscus is the next common structure that gets injured. And meniscus is nothing but two discs that God has given us to take pressure off the cartilage. So when we have pressure on, in an injury, when we have pressure on the meniscus, they may tear. So meniscus tears is like this. This is how they look. So you have the joint in the top, joint in the bottom, and this is the meniscus, which is torn. And this is where it's torn from. You see that line? This is supposed to be till there. And this is a camera picture, obviously, so I can't make it any bigger than what it is. So what do? We repair it with an arthroscopy. And you can see how it should look. That is the thread that we have used to repair the meniscus. So it's back to where it belongs. Now, why do we need it? Why can't, previously what we used to do is we used to take the meniscus out. Often commonly described as meniscectomy. Now what would that do? So if you see, you have the top cartilage surface, you have the bottom cartilage surface, and imagine this much meniscus is not there. So this surface is touching this surface, and you have no cushioning. So if that is the case, then the pressure on this articular surface increases. If the pressure increases, you will get wear and tear, you'll get arthritis. So people who've had meniscectomy in the past now get arthritis. So 5 years, 7 years down the line, the knee wears out and they end up getting a replacement. What it does for a sportsman, it reduces their work life. So their effective career is shortened if we take their meniscus off, because the recovery time certainly is less when it comes to meniscus taking out or meniscectomy, because there's nothing to heal. Whereas with a meniscal repair, the recovery time is increased by only 3 weeks. But the longevity of that athlete is increased by years. So meniscus repair is the treatment of choice. And this is what happens. So this is a girl that I've repaired meniscus on. And she is 7 weeks. So you don't have to think meniscus repair matlab bed rest. Nahi. That is not the case. So they walk normally. They wear a brace to support the knee, but they can walk normally. And 7 weeks. So that is the state of play. Next, the third structure, cartilage. Now, we do not have a replacement for cartilage. The only replacement for cartilage is replacement. That's a joint replacement, full stop. Which means we replace the cartilage with a metal. So we do not have an effective treatment for cartilage treatment. However, our athletes, young isolated cartilage damages can be treated by various procedures, of which one is taking the fracture that is there. You can see that that's an osteochondral fracture. That has come off. We take it and we fix it back to where it belongs so that it heals. The next is we use stem cells from the bone marrow. What it does, it gives you a scar tissue. It does not give you the cartilage that God has given you. However, it gives you a scar tissue which is very, very consistent or very, very near to what God has given you. So it does not give you scar tissue that you would have got otherwise if that cartilage defect was left alone. It gives you a more resilient scar tissue. Okay? And that is what it is used to fill. So large defects, we use them to fill. Small defects, we take cartilage and we plug it in. Okay? So this is kind of in a nutshell what you can get in the knee from sports point of view. So that brings us to shoulder, which is the next commonest joint that gets injured. So what are the major shoulder injuries? A major shoulder injury for any athlete is a dislocation. So you can get a simple dislocation that can range from anybody from a 20-year-old or a 17-year-old to a 50-year-old or a 55-year-old. Or you can get what we call as a fracture dislocation, which means it dislocates, but it also breaks. So the bone breaks. Now treatment of both is different. For treatment of pure dislocation, we get an MRI, we find out what is broken. So what is broken often is the labrum. Labrum is a tissue that keeps the shoulder in place. Now if you see shoulder, it's the only joint that can move 360 degrees. Which means the ball is 3 or 4 times bigger than the socket. That is the only reason why it can do that. So if the socket is 1/4 of the ball, there has to be tissues that will hold the ball to the socket. And those tissues are called labrum, and they tear off when you have a shoulder dislocation. So how do we treat them? So we don't be very clever, we just use a little thread and we tie the labrum back to the socket. So it acts like a constraint. So that is what we call as arthroscopic bank cut repair. Okay? When we have a fracture dislocation, we don't do any hi-fi stuff, we replace the fracture to where it belongs. So we use plates and screws to hold the fracture back in place. And that puts the joint back to where it belongs. So what are the results of shoulder dislocation? Both of them are young guys, and this is what you get. So there is no restriction. People often think, will I be able to bowl again? Will I be able to play badminton again? Yes. However, 3 months to 5 months, you're able to get full movement. In those 3 and 5 months, you've not strengthened your shoulder. So you try and work or play in a shoulder that is not very strong, you're likely to dislocate it again. So you strengthen, you can play. If you don't strengthen, you can't play. The next commonest is a rotator cuff tear. This happens from everybody age of 30, 35 to 70. Okay, what is a rotator cuff tear? We have muscles around the shoulder called the rotator cuff that moves the shoulder, that is torn. Now God fortunately has given us 2 sets. We have the deltoid on the outside and the rotator cuff on the inside. And deltoid often compensates. However, when you try and isolate the rotator cuff, you would find weakness. So it is not that they cannot lift their arm up, but they feel that the arm is weak. It is not as good as it used to be. And what do? We get an MRI, find out where the tear is. So that is your rotator cuff. That is where the tear is. And that is where the remnant of the muscle is. What you see here is the deltoid. So the deltoid attaches here. So it tries to lift the arm underneath the ball. Whereas the rotator cuff lifts the arm from the ball. So that is the difference. What do? We put a camera in, we find where the tear is. What you see, there. What you see there is the tear. That is the bone. That is the tear, and you can see the gap. Now, no tissue is going to fill that gap. Cells can't jump. So that is going to stay as a gap. So what do? We take some threads, and we put the cuff back onto the bone so that it heals onto the bone. Now, rotator cuff tear, what is the outcome? What can we do? Will we have stiffness? How long is the recovery? Often said, 9 months to a year. I'll show you something that you'll be surprised. This is 8 weeks. And this is 100 kgs. And this is post-rotator cuff tear. And this guy is my colleague. Okay, so often people would know this guy is Neeraj Vora. So he's an arthroplasty surgeon. He does joint replacements at Nanavati, robotic joint replacements. Okay? So that is him. So so these guys come with a demand. Gautam, I want to go and operate again. I can't be out for more than X amount of time. So he's been operating at 4.5 weeks from the surgery because he's lifting 100 kgs at 7-8 weeks. But this is what I see normally. Okay? This is 14 weeks. This is one of my patients. And this is what they get. So at 14 weeks, they should roughly get full range of movement, reasonable amount of strength, and they should be doing everything that they want to do. There should not be any restrictions. They might find restrictions going at the back, and that keeps getting better because we don't often need to go behind our backs. Now, deviating a little bit because it probably might be relevant to this group is frozen shoulder. Now, frozen shoulder is a very common problem seen by you guys. Less common seen by me. Often seen not as a sports injury, but as a shoulder problem. What is frozen shoulder? A frozen shoulder is a shoulder that is completely red or inflamed inside the shoulder joint. What it does, it causes stiffness and pain. That is the commonest problem they complain of. So, how do we treat them? The patient comes to you like that, you start treating them with painkillers, physiotherapy, you give them a trial for a few weeks, you give them a trial for a few months, and then you are like this. What next? Is this patient going to keep coming to my clinic? Am I ever going to solve this problem? Is there anybody who can help me? So, can we help you? Yes. So there is a little scope in a certain degree of frozen shoulders, there is a scope of surgery. And this is what a normal shoulder looks like. And this is what a frozen shoulder looks like when we put a camera inside. And you can see the difference. So, what can we do? We can cut this red bit. So we can cut the entire red bit out. We cut the entire red bit out, the pain's gone, movement comes back. And this is the fastest recovery you get. So frozen shoulder is very, very satisfying surgery because the patient's very happy. And the doctor is very happy because it happens in 2 weeks. 2 weeks, stat, shoulder moves fully, pain is gone. So that is where frozen shoulder, surgical treatment of frozen shoulder comes. However, I must say there is a limitation to this. This cannot be given to every patient. It is a certain degree or a grade of frozen shoulder that we offer this surgery. So surgery is not the solution for frozen shoulder, but surgery plays a part in frustrated patients to help them with range of movement and pain. And then comes arthritis. Uncommon, not uncommon disease, but less awareness. Because unfortunately, we don't walk on our hands. If we were walking on our hands, I'd get more patients. If you have pain in the shoulder, if you can still do things, take a painkiller, people continue. That is how our system is. But that's okay. Because what you get is pain, restricted movements, degree of functionality is lost. And often I get patients who are unable to get to their face, get to the top of the head, can't wear clothes, can't comb their hair. And that is when they seek advice. So what options do we have for them? So we have an option of what we call as anatomical shoulder replacement. So what is an anatomical shoulder replacement? It is when we replace socket with socket. And you can see a small radiolucent area that is a plastic or a poly and a ball. So we replace ball with ball, socket with socket. That is anatomical shoulder replacement. Why is it called anatomical shoulder replacement? Because it has to behave like a normal shoulder, which means it needs the rotator cuff to function. If the rotator cuff does not function, this will fail. So if it fails, or we have somebody where the rotator cuff is poor, we give them a reverse shoulder replacement. What is a reverse shoulder replacement? The ball is put on the socket, and the socket is converted to ball. And what does this give us? This gives us 18 years of outcome and hassle-free. Because the problem with anatomical is that if the rotator cuff fails, the anatomical will fail. Which means we are still hoping that the rotator cuff continues to function in a patient who is reasonably of age and arthritis. Now the biggest problem with late presentation in arthritis is the cuff is poor because it's not functioned. If the shoulder hurts, you will not move it. If you don't move it, the muscle does not work. If the muscle does not work, I will not get a good muscle, and I'm always thinking 2 times that if I do an anatomical, will this patient come back to me in 3 years' time and tell me, doc, not working anymore? And then I have to counsel him for a reverse. But sometimes we have to do that. Say if somebody comes to me at 45, RA, we would give them an anatomical shoulder, we'll not give them a reverse. Because reverse still has a life. So this is a real patient. This is what a reverse looks like. This is done here. And these are the results. So this is a 3-month result of reverse. And there is restriction, but functional. This is a year of result. This is a 1-year reverse result. And this is a 5-year reverse result. So since the day I started, I have all my results of the reverses. It is a rule, they have to come every year, they have to get an X-ray, they have to show me. Because we don't know how long this will work in our population. All the data we give you is from Caucasian population, which is the Western world. And we don't know how they behave in India. So we are keeping a tab, at least I keep a tab of all my patients where I do reverse replacements. So that brings us to elbow. Elbow, commonest, tennis elbow. Tennis elbow essentially gives you pain and inability to work or recurrence. It keeps coming back. Can be acute, can be chronic. Often seen in athletes. Initial stage of treatment is non-steroidals and a brace. Give them that, take them off the repetitive work, and in my practice, 6, maybe 7 out of 10 will heal like this. I don't have to go forward. The 3 or 4 that don't heal, they become chronic, and I get an ultrasound scan or an MRI scan. And what do I see? I see a tear. Now, if there is a tear, then it is either partial or complete. A complete tear, there is no rocket science, it needs something doing. However, partial tear, we can try them with physiotherapy, eccentric exercise, and hope that the remnant of the muscle that is there might take over and give them the function that they need. So we give them eccentric exercises with physiotherapy. If that doesn't work, we can try what we call as a PRP. PRP is essentially platelet-rich plasma. In a nutshell, it is taking your blood, taking the healing products out of your blood, and injecting where it needs the most. If that does not work, then we have an arthroscopic solution for it. Because there is scar tissue, we put a camera in, we take away the scar tissue, we get new healing tissue. If arthroscopy does not work, then we have an open solution for it. So open solution, and this is what we can get. Now tennis elbow takes a longer time to heal, and this is sort of 8 months and they've gone back. So this is a guy who plays in GSE and has gone back to play the tournament and win the tournament. There's post-tennis elbow surgery. Next is a biceps. Now this is a pure sporting injury, and it is effectively an injury which happens into eccentric exercises or eccentric loading. So people who involve themselves in good eccentric exercises and work. So this is what they get. They get a pain or a popping. You get an MRI and you find a tear. How does it look? It looks like that. What do? We repair the biceps back to where it belongs. So that is the surgical scar for the bicep repair. That is the bicep tendon that is torn. And this guy is an ex-Maharashtra Shri. So he needs his bicep. He wants to go to the gym. And he's not going to listen to you. And what can we get? We give them a brace after we've repaired it so that they gradually improve. And this is what we get. So this is 3 months in the gym, and they'll not listen. They will just not listen. They just keep doing. But it is glad that you can get these kind of recoveries. Which brings us to hand and wrist. The commonest, so this is pretty much the end of the... So in hand and wrist, the commonest is the ligament of the thumb. That is the commonest ligament that gets injured. Apart from conservative treatment, we get an MR. Conservative treatment is a plaster. If there is a tear of the ligament which is in place, it will heal. If there is a tear of the ligament that is not in place, it will not heal. It will have to be brought back in place. And that is what it looks when it is torn. So you can see there is a gap between the bone and the ligament. We repair that, we give them a splint, and this is what they get. Okay? They have full movement back, and they can function normally. That is me end. So I think in a nutshell what I'll say is sports injuries and its treatments have moved leaps and bounds. There is no longer the didact that it has to wait 6 months, it has to wait 9 months, it has to wait a year. We are bringing patients back. 3 months and 4 months is what our average recovery is. Sports guys will come back in 2 months, 2.5 months, depending upon how much input we can get from physiotherapy.
Thank you, Dr. Tawari, for an excellent and enlightening session. I would like to call upon Dr. Patel, Dr. Badwe, and Dr. Jafar to felicitate Dr. Tawari and Dr. Kocher, obviously.
मैं हैंड ओवर करती हूँ।